Hello, my name is Leanne Flowers. I'm a family nurse practitioner student at Auburn University. I'm going to teach you today a little about diagnosing GERD. So, gastroesophageal reflux disease is the movement of the gastrointestinal contents into the esophagus or beyond. It's facilitated by a decreased lower esophageal sphincter tone. This can be physiologic. This disease is present when gastric contents flow upward into the esophagus or the oropharynx, and it's producing these symptoms. So you have some risk factors for this condition. There's many, as you can see. I'm going to only hit a couple highlights. Alcohol, caffeine, overweight, pregnancy, certain drugs and certain conditions can definitely start leading you in the direction of this diagnosis. So when you're taking a history from these patients, you want to focus on determining if this heartburn or indigestion is acute, is it situational, is it pathologic? Is this a family history, social history as far as alcohol and smoking? What are their medications? Do a med review. What are their chronic illnesses? And you want to see what those aggravating and ameliorating factors are, which could be the improvement. So what aggravates, what improves? More questions that you can ask. Is this typical symptoms? Is this atypical symptoms? And diet, alcohol, tobacco use. Are you seeing these symptoms while bending or lying down? Your physical exam is often going to be benign, but you can look for esophageal mass or epigastric tenderness or dental erosion. You want to focus on vital signs, weight, BMI. You want to do a complete abdominal exam and heart and lung exam to make sure there's no aspiration or anything going on with that. I love this little algorithm. That's why I included it. But it starts out with, giving you your symptoms, encouraging your lifestyle modifications, and then it goes into these alarm features. If any of these alarm symptoms or features are present, you do, have a complicated GERD and you do want to go ahead and proceed with an endoscopy and biopsy. And if you don't have this complicated GERD and you just have atypical symptoms, is this, something that's complicated or uncomplicated atypical symptoms, and you're wanting to try your drugs and you're wanting to, get your patient down to the lowest effective dose possible. Also, again, we're going to, as far as treatment goes, you're going to start out with these lifestyle modifications. It's a great little picture just to sort of go ahead and start showing your patient they need to quit smoking, exercise, sit up straight, eat small meals, chew their food slowly, wear loose clothing, sleep with their head of the bed up, and avoid eating at least 3 hours before bed. Some more treatment can be your H2 blockers like famotidine, 20 milligrams BID. You can do your PPIs, but they're, usually take a couple days to become effective. They're not instant. And, these do come in liquid form for your pediatric population. You can do antacids and barrier agents such as the serocofrate for breakthrough symptoms, and surgery is also an option if you've exhausted all treatment options and they need a surgical consult. You want to educate these patients to, again, maintain healthy weight, avoid eating before bedtime, don't drink alcohol, don't smoke. And then you want to talk to them about when do they need to come back to the doctor, and when should they seek further help with us. Are they having chest pain? Is it not getting better? If it's getting worse, if they're having unintentional weight loss, if they're not feeling better with treatment, of course, wheezing, chest pain, difficulty breathing, any of that, then they want to come back. As far as a regular follow-up, you can follow them up and within their 3-month period if you just start them on a PPI or something like that, and lifestyle modifications. So that is it on GERD. I appreciate you listening.